You are listening to the Keeping It Juicy podcast.
Your main squeeze in nutrition.
Don't forget to subscribe so you can join us every Tuesday for a brand new episode.
Also, don't forget to add us on Instagram and Facebook at Keeping It Juicy Podcast.
All right, welcome back to our show. Today is episode 79, and today we're going to be talking all about health disparities. If you don't know what a health disparity is, you definitely need to stick around because it means you need to know even more so than everyone else what health disparities are and what you can do about them. But before we get into that, we are going to be going over our new nutrition in the news. And the title of this article is Vegetarians Tend to be Slimmer and Less Extroverted Than Meat Eaters. So I found this study super interesting because it actually studied the trend or the relationship between dietary preference and personality type. So I found that super interesting. I mean, no shame or anything, but if you think about vegans or some other paleo, keto, whatever, there are sometimes certain, personalities that tend to go with this type of dietary choice. So this study, for example, looked at being extroverted or more introverted with being a vegetarian. And it also looked at BMI. So it was found that the less animal food in the person's diet, the lower their BMI was, and thus their average weight. One reason could be that the vegetarian diets had a lower proportion of processed food than the plant-based diet. We've talked about this many times before. We know this, but we also know that vegan and vegetarian foods can be just as processed as whole, foods that have animals in them as well. So something to keep in mind. So the researchers also found that vegetarian or vegan diets were also related to personality, especially with one of the 5 major personality factors, which is extroversion. It was shown that people with predominantly plant-based foods in their diet were more introverted than those who mainly fed on animal products. And here's a quote from one of the study leaders. She said, "It's difficult to say what the reason is, but one of the researchers said it could be because more extroverted people tend to have more restrictive eating habits, or because they are more socially segregated because of their eating habits." Again, further studies should follow up on this and see how people identify with the characteristics of their diet. So I found that really interesting. It's almost a question of like what came first. Is it the personality that influenced the diet, or did the diet influence the personality traits over time? So something to consider, something that maybe can or should be looked at in further detail. However, they could not confirm that a plant-based diet is associated with a tendency toward neurotic behavior, as other studies suggest.
Isn't that term itself neurotic behavior? That's not a good term.
Well, neurotic, if you know about what is it, the big 5 personality traits, being neurotic is one of them. So we're not calling you crazy. We're just saying that neurotic behavior in past studies has been shown to be associated with plant-based diets. Not saying y'all are crazy, again, but some studies have suggested it. All love. The study leader said that earlier analysis have found that more neurotic people were generally more likely to avoid certain groups of foods and to behave more restrictively. We focused here solely on the avoidance of animal products and could not observe any correlation. I mean, it makes sense. If you have a more restrictive style of eating, over time, maybe some other areas of your life are going to become more restrictive as well, like where you go to eat, what cleaning products you might even, like if you choose to be vegan for animal rights and like sustainability, you're probably going to start buying different clothes, buying different cleaning products. Like your whole outlook on, life could change too, and just your whole perspective on different issues will change. And that sort of control can be seen as potentially neurotic behavior.
Not necessarily saying it's bad that you're going in that direction. It's just Obviously, this is not going to apply to every single person that's
But
vegetarian,
it
but
is
that's
interesting to, I think it's very interesting to know, is it the diet that is causing that behavior, or is it the personality type that exists prior that causes more people to turn to these more restrictive styles of eating? You know?
yeah. I just want to know who decide, like, why did they even decide to look at this? Were they just friends with somebody and that just caused them to question things, and then it just went from there?
I don't know. I mean, that'd be an interesting question, but it is kind of bridging the gap between personality behaviors and dietary choices.
It might
Um,
it might help explain the behavior of one person that we know. Anyways,
moving on.
uh, so we're gonna go ahead and move on to the main topic of this episode, which is kind of already bouncing off of last week. So last week we talked all about the issues with diversity within the dietetics field, and then this week we're kind of gonna bounce off of it and talk about why that's so important and why this is something to consider moving forward in regards to helping our patients and our clients and just overall public health. So if you, if you stuck around, we're going to let you know and talk about health disparities. So first off, what are health disparities? So health disparities actually refer to varying rates of morbidity and mortality from various health conditions, as well as to differences in access to healthcare and quality of care that exists across diverse populations within the United States. Among the demographic characteristics associated with the greatest degree of health disparities observed are actually gender, race, and ethnicity, socioeconomic status, education level, disability, sexual orientation, and geographic location. So these are all very important. These disparities have actually led the United States Department of Health and Human Services to establish as one of its primary goals for Healthy People 2020. So the National Health Promotion and Disease Prevention Initiative is basically talking about the elimination of health disparities, which is actually very common if you look at the public system close enough.
I wonder if their 2020 goals are going according to plan.
Nope, not at all. I promise you that. We should probably do an episode on that. Like,
Oh man,
I don't.
2020.
Mm,
So, although some disparities in access to care and quality of care have decreased since the 2005 National Healthcare Disparities Report, which was actually published by the Agency for Healthcare Research and Quality, which the acronym is AHRQ, a gap still remains. This large gap refers to the quality of care and the actual access to care. It's extremely important to understand that health disparities have remained largely unchanged for African Americans, Hispanics, Asians, and all low-income populations, as have over 60% of core healthcare quality measures for African Americans, Hispanic American Indians, Alaska Natives, and other low-income populations as well. Overall, the goal of eliminating health disparities is just not being realized. Independent of race, ethnicity, and income, lack of health insurance is the greatest risk factor for disparities in quality of care. However, disparities in the healthcare equality exist across racial and ethnic groups among the insured as well.
So there was actually a report that came out from the Institute of Medicine's 2003 report where they talk about the unequal treatment of confronting racial and ethnic disparities in healthcare. Racial and ethnic minorities are more likely to receive less desirable procedures, which, why the fuck? Just as age and severity of illness do not explain disparities among the insured, these variables do not explain why rates of appropriate and favorable medical treatments are significantly different among races. These objective measures are complemented by subjective indicators, which underscore the need to improve healthcare delivery to these diverse populations, namely the need for improving the cultural competence of the actual healthcare organization and personnel themselves. Yikes. I mean, much of our knowledge of racial and ethnic disparities have actually been derived from national population samples that have been taken pretty recently. But efforts, like she said, to eliminate these health disparities have to actually occur, and in order for them to occur, it has to be done in collaborations with the local and regional and healthcare organizations, communities, healthcare institutions, and healthcare providers. Like, we're talking about all of the providers, not just dietitians. We're talking about physicians, we're talking about nurses, every single one of them. So that's a big issue.
So, is there anything else causing this imbalance that we see today? So, if you don't see an issue with the level of care that some people are receiving right now, then you need to wake up, because you might have the privilege that is kind of contributing to why some of these problems exist. So,
Your
of course,
your privilege is showing.
which is showing. Cover
Yeah.
that up.
Yeah, like, see what's happening, just put it away.
Oops.
Okay.
Okay. Of course, the healthcare system can't be deemed the exclusive cause of health disparities. There are various social, economic, and environmental conditions that also contribute to many of the forms of inequalities that impact health. And we're going to go over some of those other indicators right now. So, age is one of them. Older people are just more likely to have chronic disease, and that's just the way it is. As you age, you're more prone to get disease. It is what it is. And another thing is, as nutrition professionals and healthcare professionals, I think it's important to keep in mind that elders tend to be stuck in their ways. So if you have an elderly client, instead of like trying to introduce them into a whole new style of eating or lifestyle, just try to optimize like their current food choices, because they're older, they're stuck in their ways. Just work slowly with them and optimize what they're already doing. Another health disparity is gender. So women are actually more likely to have chronic diseases. One reason for this is because women tend to wait or live longer than men. So we live longer, we get more chronic diseases. Go us. Um, but although women are more likely to have chronic disease, men are more likely to die of the most common chronic diseases, which are diabetes, heart disease, and cancer. So diving more into that, men have a significantly higher death rate for heart disease and cancer as compared to women, but only a slightly higher death rate for diabetes.
And another health disparity that we typically see is one of the more important one is socioeconomic status. So the conditions in the places where people live, learn, work, and play plays a huge role into the wide range of health risks and outcomes that we see. And these conditions are actually known as social determinants of health. So SDOH, if you didn't already know that from your public health class. But we know that poverty limits access to healthy foods and safe neighborhoods, and that the more education is a general predictor of better health. We also know that that differences in health are striking in communities with poor SDOH, such as unstable housing, low income, unsafe neighborhoods, or just substandard education in general. And then another huge health disparity comes from race and ethnicity. Health disparities between different racial or ethnic groups are caused by differences in genetic factors, environments, or health behaviors. Minority populations often have a higher rate of chronic disease in general. Death rates for diabetes, heart disease, and cancer can vary widely by racial and ethnic groups. For example, Black or African American, American Indian, and Hispanic groups are more likely to die of diabetes. Black Americans and white groups have a higher death rates for heart disease and cancer. For all three diseases, Black Americans have the highest death rates, while Asian Pacific Islanders have the general lowest. So that's a huge difference, and that's something that you want to consider when you're treating your client.
Mm-hmm, mm-hmm. So how does cultural competence come into play? Dietetic professionals must be able to identify and address cultural characteristics and preferences of ethnic groups to provide optimal care to their clients. This equates to not only having an understanding of beliefs and behaviors of the culture, but also being able to reflect on one's own attributes, values, skills, and attitudes that may impede interactions with the other culture. According to Transcultural Care Associates, which is an organization that offers cultural competence counseling to healthcare providers, the following 5 constructs of cultural competency that healthcare professionals should strive to achieve. So, the first one is cultural awareness, which is basically self reflection on one's own biases towards other cultures. We all have a bias, and it's important to recognize kind of what your bias is, because that's kind of the first step in overcoming it. It's really rare to be able to say, like, oh no, I have absolutely no bias. Like, I'm great, I'm perfect. Like, no, you're gonna have a bias. It's normal, it's okay, it's human nature, but just know what it is so that you can overcome it and not provide suboptimal care to someone because you're too on your high horse to realize like what bias you have and do that internal work yourself. Also, cultural encounters. So, engage in cultural interactions to better understand the culture and eliminate stereotyping. If you're surrounded by the same type of people all the time, you're never going to have those harder or different conversations to increase your cultural competence either. And then improving your cultural knowledge. So use reputable sources to develop an understanding of diverse groups, including health related practices, cultural values, and common diseases. We briefly touched on it, like ever so briefly, like which cultures and races are more susceptible to some diseases. Like, do more research if you have a certain type of common culture that you see in your practice or where you live, because it's going to vary. And then cultural skill, so provide culturally tailored assessments of clients. You might need to ask different questions based on your knowledge of that culture. And then cultural desire, so actually have a genuine interest in understanding the cultures that you work with as opposed to making it a task. um, I've definitely seen that before. I've seen people say like, "Oh, they're different, they're weird, I don't wanna work with them." It's like, "Okay, okay."
Or I think the worst one that I saw was at a WIC clinic. One of the staff members, I'm not going to say what, one of the staff members was complaining about a lot of the patients being Spanish speaking. I'm like, I don't fucking know what to tell you. There's a lot of
Yeah,
there's a lot of Hispanics in America. Just like do your due diligence and maybe learn little bit more Spanish and
try
understand
your
a little bit
best.
more.
Yeah, just
Just
try your
something.
best and don't complain about it. And another important part is to also understand just socially how different cultures view body image as well. I think this is a big one that we don't talk about enough. So the US has glorified the kind of bikini body and model figure for decades, and we are breaking that with the body positive movement. But even prior to our recent body positive movement here in the US, other cultures do view other sizes as a sense of wealth and fertility. And I think that's really important to know, especially as the conversation of body image is opening up a lot more. Understand that people of different cultures, races, and even religions are not going to have the same body image ideas that you do. And that's perfectly fine.
And as we go forward, not only do we really need to improve our cultural competency, but really trying to identify that barrier to health. So actually, with the United States' diverse population and wide variety of cultural cuisines, which thank God we have them, even when clients originate from the same country, practitioners must get to know their clients, including their meal and their snack patterns, food likes and dislikes, and cooking styles. All these actually, they actually have to go a step further and must identify cultural food and health beliefs to be able to develop a rapport with individuals they counsel. And there are some recommendations for practitioners. So when RDs work in culturally diverse populations, the following are very good practices. So building that rapport with clients, showing an understanding of their foods, culture, and ingredients, conducting extensive research on countries of origin to determine influence on unhealthful dietary practices, using that motivational interviewing to empower clients to work with you to make joint decisions which respects the client's individual needs and preferences. This includes asking open-ended questions, providing clients with affirmations, reflective listening, and just a summary of your discussions. And lastly, develop culturally appropriate assessment forms to help identify barriers to healthful eating within the population. And that's very huge, because like we've said it time and time before, one size does not fit all. Everybody needs to be approached differently. How they approach me is going to be very different from how they approach you, as an example.
So I did want to talk about briefly an example of National City, which is considered a food desert. So National City is like a subsection here in San Diego, and it's always been kind of like an area of interest to me. I did a couple internships in this area. So basically, it's considered a food desert because the area itself doesn't have fresh fruits, fresh vegetables, and other whole foods available within like a certain geographical limit. And there's also not like working sidewalks for people to walk to the grocery stores. So it is considered a food desert due to the just lack of resources. So poor dietary status comes as a result of this. And for over a decade, the Environmental Health Coalition, which is the EHC, has worked with residents in Old Town to address this food desert and food insecurity. And then responding to an EHC community survey in 2015, the residents were actually, I'm sorry, 2005, the residents were already voicing their concerns about the lack of affordable food in this area and kind of how it affected their daily lives. So this issue in National City has been going on for a very, very long time. There's also so many more convenience stores than just general grocery stores. There's almost twice as many. And now I want to talk about kind of the result and some of the other factors that are contributing to National City being a food desert. So over 50% of the children in the National City School District are overweight or obese. That's half. More than half of them are overweight or obese because they're living in this food desert. And National City residents also have the highest rate of heart attacks in all of San Diego County. It's just crazy. And now when we look at the actual population of National City, 64.4% is Hispanic or Latino, 19.5 are Asian of some descent. It doesn't go into actual differences. And then less than 10%, 9.47, are white. So whites are the minority here in National City. So we can see how race is playing a part into the health disparities here. And then actually households in National City have a median annual income of about 43,000, which is less than the median annual income, which is about 61,000 in the whole United States. So San Diego's expensive, more expensive than many other places in the US. And then the annual household income is about 20,000 less than the average income across the US. So you've got socioeconomic status, you've got racial status playing a part, and this is the result: the most heart attacks and the most overweight and obese children. So just a prime example of a health disparity kind of crisis here in San Diego. I can almost guarantee that many, many, many towns, you can think of one that kind of like fits the bill in your city or state.
I don't know. That's just I've always heard about National City, even when I
Mm-hmm.
was in San Diego,
Mm-hmm.
and everyone was always talking about it. I think that weren't they already starting to make changes though? I think I thought last time I was there they were pushing for a grocery store, if I wasn't mistaken, and then maybe a community garden. I'm not entirely sure, but um
So I interned at a facility that did kind of field trips for kids. in the
Mm-hmm.
National City School District, and we taught them how to cook. Like we hosted
Right,
little
I
cooking
remember.
classes. There was a garden there, so we showed kids like, hey, carrots come from the ground, and
Right.
many didn't even know that. So we really taught them, where food comes from. We had chickens, so we showed like you would ask the kid like, okay, where do eggs come from? And the kid would say, from the cardboard box. And it's like, no, it comes from this chicken.
Right.
So just little things like that we would teach them, and soil cycles and just
Right.
other things like that too. There's some science, um, ecosystems and things of that
Right.
nature.
I
Um,
know. I know. Right next to our work, there's a garden like that too, with
mhm,
chickens and roosters. I
yeah.
think I actually popped my cherry, and when I first heard a rooster make a noise,
Like,
like I walked by
where's
and
this going here? What
I
did you
heard.
say with the rooster?
No, I was walking by on my usual daily walk, and I just heard a rooster, and
Oh,
I was like, "What the fuck is going on?" Like me at 24 years old at the time, I was just like, "What the fuck?" So,
rooster.
but no, that even that place I've seen that they hold classes like that, and you can actually volunteer
Hmm.
to do that as well.
Hmm.
So yeah.
Yeah. If you live in a city where there's a lot of health disparities or food desert, we're very interested to know maybe what your city is doing about
Hmm.
it, or what you've seen work or not work. If you have any
Hmm.
additional knowledge on these sorts of things, we're totally open to hearing that. And with that being said, we are going to close out with our social media shout out of the week. It goes to Ty Talks Nutrition. I hope I pronounced that right. And she's a UK registered dietitian getting her PhD. So, congratulations. She
Impressive.
posts just amazing evidence based nutrition graphics, and they're just extremely thorough and educational, but well written so that they are educational, but they're also simple enough that if you maybe didn't go to school for nutrition, you can still get the gist of it, you know?
Right.
Mhm.
Right.
Kind of a nice
Um,
blend of sciencey, but also kind of some layman's terms as well. So you can maybe send it to someone who doesn't know about X, Y, or Z topic, and you want them to learn more about it. So great page. Thank you for your support. We definitely appreciate it. And if you don't already know,
mhm.
we are still giving out these stickers to all of our social media shout outs. So even more incentive
Mhm.
to like our stuff, send our stuff, comment on our stuff,
Mhm.
all the stuff.
Yeah. So no, we do appreciate it. Even all the way from the UK, we see you, and
Mhm.
we see you
Mhm.
supporting us, and we'll
Mhm.
support you back.
Yeah,
Um,
absolutely.
but like you said, if you want to be a social media shout out, just like our shit, send us shit.
All the shit.
um, all the shit. But it realistically, this was a heavier topic this week too. Last week was pretty heavy. This week is heavy as well. But it's something important that we need to talk about. I feel like we don't talk about it enough. Like, granted, nothing's really going to change from just one episode. That is
Mhm.
not realistically going to happen. It's going to happen through action alone, through anyone's part, my part, your part. So this is just something to consider as you go
Mhm.
through, not only in your profession but in your everyday life. That one thing is not causing an action of something else. I don't know if I even
Mhm.
said that correctly, but
Mhm. It's not
just
just race, it's not just socioeconomic status, it's not just gender, it's not just
mhm.
the healthcare system. It's a lot of different things, and
With that being said, we'll probably end off the show like the same way I ended last time.
let's hear it. Go for it. Do your thing.
Stay safe out there. Don't touch anybody, and don't let anybody touch you, because COVID is still happening.
It's not gone, guys. It's not
No,
gone.
it's actually gone back up. So,
I know. All right. We will catch you guys in the next one.
bye, guys.
Bye. Thanks for listening to the Keeping It Juicy podcast.
Your main squeeze of nutrition.
Don't forget to subscribe so you can join us every Tuesday for a brand new episode.
Also, you can find us on Instagram and Facebook at Keeping It Juicy Podcast.
We'd love to hear from you, so please leave us a review.
5 stars, no less.
On whatever platform you're listening to, or send us an email at keepingitjuicypodcast@gmail.com.
Or if you have any topics you'd like for us to touch upon, shoot us an email. Until next time, don't do anything that I wouldn't do.